So no doubt we are all here want to make a anemia mukt Bharat. क्यों नहीं चल रहा है? क्या हो गया? Ruchika, can you take over, please?
Ma'am,
first case. Let me see why it is hanged.
So yes, without wasting the time, let us start our first case. So we have a 15-year-old girl and she presented to the OPD with 1.5 months of amenorrhea followed by heavy menstrual bleeding. And on examination, we found that she has 2-degree pallor. Hemodynamically, she was stable and there was no thyromegaly, breast and pubic hair development was okay. And per abdominal examination was also okay. On local examination, her external genitalia was normal. There was no injury such thing and bleeding was present. And per rectal examination also revealed adnexa and uterus were normal. So, problem is, yeah. So what are the important points in history we should take from this patient? May I know expert comments from Sarogi, sir? When an adolescent girl with such symptoms come to us?
Good evening, everybody.
Yeah, welcome, sir.
First and foremost, this should be labeled as puberty menorrhagia.
Yeah.
And it is basically due to immaturity of hypothalamo-hypophyseal-ovario-uterine axis.
Yeah.
It's basically due to anovulatory cycles which occur at extremes of ages. The studies have shown that early menarche occurs in cases which are obese with high BMI, and certain environmental factors may be responsible for early menarche. Now, why I'm talking about early menarche is, if age of menarche is less than 12 years, this is for the August audience, the duration to attain ovulatory cycle is 1 year. If age of menarche is 12 to 13 years, duration to attain ovulatory cycle is 3 years. And if age of menarche is more than 13 years, duration to attain ovulatory cycle may vary up to 4.5 years. Why I'm trying to tell you this is, ultimately when it comes to treatment part, the counseling is the most important thing, and you should be prepared with the idea that this patient is likely to have anovulatory cycles more often, and if anovulatory cycles are there for 1 year or 2 years, she is likely to have these problems more frequently. Now, why in anovulatory cycle do we get bleeding? Basically, if you try to understand, there is imbalance between vasoconstrictor and vasodilator. PGF2 alpha under the influence of progesterone is vasoconstrictor, while PGE2 and PGI2 under the influence of estrogen are vasodilator. In anovulatory cycle, because there is no progesterone, there is no PG2 alpha. As a result, there is vasodilatation and bleeding occurs. What is more important again in this is, if you try to look at adolescent age, cycle frequency is normal 1 to 45 days. So again, you will have to counsel the mother about the duration of flow can vary from 4 to 8 days, and volume of flow can vary from 4 to 80 days. So all these things are important as far as treatment part is concerned, as far as counseling of the mother and the child is concerned.
Yeah, Niharika, would you like to, Niharika, are you there? I got a message that she
I'm here.
Yeah.
I'm from the OT, yeah.
Okay, good. So what all points in history we have to give emphasis in this case, that she had amenorrhea followed by heavy menstrual bleeding?
Yeah, so when we are talking about adolescent anemia, we have to understand that these children will have reduced, physical development, cognitive development, and even sexual and reproductive development. So when we are taking a history, a complete detailed menstrual history with age of menarche, any problems like acne and hirsutism, and also of course if they are taking any drugs, and a complete family history, even a socioeconomic history here is very important, because as we see in, especially in poor developed areas or in poverty areas, adolescent anemia is very common. So a good socioeconomic history also should be taken here.
Yeah, and we should all nowadays we should rule out pregnancy related bleeding, and whether she is taking any exogenous hormones, or whether she's on any anticoagulants, or whether she's having any bleeding tendencies like epistaxis or easy bruises or petechiae, and definitely a history of hypothyroidism like weight gain and cold intolerance, fatigue should also be taken.
Can I add?
So yeah. Sir, what anyone would like to take that? What all things we will go look for in the examination part?
For
Apart from
examination part, we will have to see about whether there are ecchymotic patches or petechial patches on the skin, because in other problems, bleeding tendencies when they are there. Then how much pallor is there, hepatosplenomegaly if there is generalized anasarca, any lump in the abdomen or any lump in the pelvis. And then
Also
gum
her-
bleeding is also important.
Also her BMI in
Yeah.
general examination, that is also
Okay,
important.
yes,
Just to
that's
rule
all.
out if she's too much obese or she's too thin. So both the BMI is not up to the mark. That can also actually add to the deranged HPO axis. So anyhow, anovulatory cycles, as sir said, are common in the early age group, in the early teenagers. And iatrogenic, actually, ma'am, what you were suggesting, because we have seen so many people, patients, they come at such young age and they are having a bundle of prescriptions with hormones. So that concept of starting an iatrogenic AUB kind, they just take 4 days norethistron, then they stop it. Then the patient will say again, doctor, I started bleeding. Till I'm taking the tablet, I'm bleeding free. And then this kind of thing which you pointed out.
Yeah, so
that's
what
important.
investigations would you suggest any of the panelists?
Yes,
What?
ma'am,
on this?
definitely she's pale. And also she is actually young, 15 years. So I will just like to run a quick blood test with the complete blood count, as was illustrated in the previous lectures. And also typing of anemia is important, which can be done by peripheral smear. We always expect it to be, because of blood loss, normo, but still we should have to rule out coexisting iron deficiency also, because in the adolescent age group,
Yes.
we come across, a complete mixed kind of a picture. So this is important. Then I will also like to rule out her thyroid, free T3, free T4, and the TSH, and also anti-TPO if indicated. Along with it, we have seen coexisted hyperprolactinemia is also there. So I'll also like to rule out serum prolactin. Ultrasound, because ma'am, I'm not doing her per vaginal, per rectal. Okay, I can just see if there is any prominent, any pelvic mass, but still I would just like to document it through an ultrasound report, because I might miss some loculated, some ascites, some tubercular mass, anything related, which I'm not very confident on my examination. So I will just like to have a reporting of the ultrasound. And also, ma'am, coagulation studies, the literature says that if there is no history suggestive of, early bruising or something, I will not like to give it the first go. I will not like to extensively investigate her against all the von Willebrand factors or protein C, protein S deficiencies, anticoagulant. But yes, I'll keep that in my mind, because if the patient comes with recurrent bouts of bleeding, or heavy bleeding, which are making him again susceptible to blood transfusions, I'll also like to explore those. And definitely, if I will just take her into confidence and I'll ask her if she is at all into any, she's sexually active. It's like rare in our population where we cater in India. But yes,
No.
if I'm practicing abroad, 15, 16-year-old
No, it's
girl,
not
definitely.
so. 50% of the
Not
girls
so.
might be.
But yeah,
Yes.
okay, yes, ma'am. Now the people
Whenever
are
there is a history of amenorrhea, that's the
yeah,
message
UPT,
also.
that's the first thing we teach to our postgraduates. So they get a
Yes.
big jar if the UPT is not done. And it's now no more a taboo also, ma'am, that's correctly said. So these are the things I'll just try to take into my consideration, and for giving her a good
one more
workup.
message.
I think we
that
can add serum ferritin also.
Yes, ma'am.
Yeah.
But actually, if the typing is normo, so I will be like comfortable in thinking that it's because of blood loss. And the peripheral smear will also give me, one like help if it's normocytic, and if it's microcytic and hyperchromic, then definitely I'll try to go for serum ferritin levels, in fact, or iron studies. TIBC, total iron binding capacities, and transferrin saturation along with serum ferritin.
Okay, and if we are going for von Willebrand's factor, there should be a gap between it and the estrogen therapy if she has been on,
Yes.
because these
Correct.
alter this thing. And
Correct.
if she's sexually active, always exclude any types of infection.
We can go for BTCT or APTT-PT for or platelet count. Before going for these fancy tests, ma'am, we can actually add these things in our basic workup.
Just
Just one line of
fever is
caution.
also becoming very important, dengue, these days.
Just
That's
one
what
line
I'm
of caution: if she is sexually active, be careful. Don't forget to inform police before.
Any
Yeah.
comments from Dr. Yashwant,
Sure.
our
Foxo
expert of
Under
the day?
FOXO, yeah, we
Yeah,
have to inform.
exactly.
Very
Dr.
good point.
Pradeep,
What's more important is
Niharika or anyone wants to take how to manage this case?
Sir is saying something.
Yeah.
von Willebrand disease exists in 1% population of USA. So we can't take it lightly now. And the recent studies have shown that if lady has a persistent corpus luteal hematoma, suspect strongly von Willebrand disease.
Yes, exactly. So that has to be kept in mind and investigated if she's having all these things repeatedly or frequently.
On the management part, how to approach for such case?
Yes, for
Any of the
treatment part,
yeah.
basic and most important treatment in the young girls is tranexamic acid, ethamsilate, and painkiller NSAIDs. And we have to, according to the workup, we have to treat the anemia also, and what type of anemia. If it is iron deficiency anemia, then definitely iron supplementation should be done. And what pathology we are able to find out, then according to that pathology, we have to give hormonal treatment, or menstrual record can be kept so that we can treat accordingly, not hurry in giving hormone. In first basic, we can give NSAIDs and ethamsilate or tranexamic acid. And if it is not controlling or heavy bleeding, then definitely we'll give to the hormonal.
Yeah, tranexamic acid and mefenamic acid by itself reduces bleeding up to the extent of 30%. But tranexamic acid can cause increased risk of thrombosis in certain patients. I mean, those who are predisposed. So that side effect we should always know. And
Would like to add here, so when
Yeah.
we're planning or any treatment, I think deworming also should be done in such adolescent cases.
Very
So
true. Deworming is mandatory.
deworming is very
Yeah.
important in such patients, and also giving them the right dietary advice is very important, because they should know what proper diet has to be taken, because it's just not the treatment which will work, it will also go hand in hand with her diet.
What's more important is tender loving care. That should have been the first thing as far as management is concerned. Now, when
Yeah.
it comes to giving ethamsilate or mefenamic acid with tranexamic acid, we generally give, I have seen prescriptions going on for 7 days, 8 days, 10 days. That's not the correct thing. What's more important is maximum you can give it up to 5 days. The reason behind it is blood loss during cycle. On first day, it is 25 to 28%. On second day, it is 45%. Third day, it is 22%. Fourth day, it is 10%. And fifth day, it is 5%. That is a natural, normal phenomenon which occurs in a normal menstrual cycle. So even if patient has heavy bleeding, you should not give it beyond 5 days as far as combination of mefenamic acid and tranexamic acid is concerned.
Yeah.
So I just want to add one more thing. Like Dr. Niharika has said regarding diet, we have to ask in history also what diet she is taking, because that is also very important. Because these days, to reduce fat, they are doing many dietary
Food faddism.
programs.
Yes.
Dieting also.
And for acute control of bleeding, what all can be given? In what doses?
High dose, yeah, exactly. High dose estrogen, or we can also give combined oral contraceptive pills, because she's a young girl, she'll benefit. And if we can give 2 tablets of oral G together, or complete 30 micrograms of ethinyl estradiol. That is the low dose OCPs. And first we can give it 2 tablets. If the bleeding is not responding, we can give it 2, and then slowly we can taper with 1 OD, and we have to ask her to continue till 21 days. She should not stop any pill, any hormone in between. So accordingly, by seeing the effect, how is the bleeding, how she's responding, we can keep tapering the dose.
Yeah,
I think
even
better would be after doing ultrasound, we can see the thickness of the endometrium and whether it is secretory or whether it is
Because, you know,
accordingly that we
Actually,
can add
they say
which
that
hormone we would like
norepinephrine
to
is the best, to control bleeding in acute hemorrhagic episodes. So
Yes, we need to give
ideally, we
OCPs.
must give norepinephrine, but if she can't afford or if we don't have that, then of course OCPs as told by ma'am. Yes.
Yeah, OCPs in, I mean, one tablet TDS or BD can also be given, but in such high doses, vomiting can be a problem. So
Nausea.
additional antiemetics
Yes.
can be added. And even nowadays, LNG IUD is a very welcome thing in even
In
India
adolescent-
and abroad.
But she's an unmarried, like
Adolescent.
adolescent,
Yeah, if
unmarried
she's
girl.
sexually active and I mean,
Then we have to
we
just
should
keep
open
this in
our,
mind.
But
I mean,
even
all
if she
options
is
should be.
sexually active, it is not open to her parents.
But sometimes we patients are ready adolescent menorrhagia, implanon can be inserted.
Implanon can.
And
Implanon
even
can-
DIMPA, dipot medroxyprogesterone acetate
Hmm.
injection can also be given. And